So hello and welcome everyone. I'm Alison Morton, nurse consultant in palliative care at the National Hospital for Neurology and Neurosurgery. And I've been asked to talk to you today about planning and end-of-life care for patients with motor neuron disease, but this could apply to any patient with a life-limiting condition, whether it's malignant or non-malignant disease. The principles are all virtually exactly the same or very similar. So planning ahead to ensure support is in place when it's needed, it is ideal, but not always possible because it's very much dependent on the patient and what agenda they have. We often as professionals go in with an agenda of thinking, oh, today we need to achieve making a decision about this patient, reaching decisions about what they would want if they were no longer able to eat or drink. But that might not be the patient's agenda. You might go and see your patient, whether it's at the bedside in hospital or in their home, and they just want to talk about how angry they feel that day, and they won't engage in conversation. So it's trying to enable those conversations to happen. Most of the time we do achieve it, but there will always be patients who you never achieve it because they will not have those conversations, and that's worth bearing in mind. And that's quite hard for us as professionals, but I think sometimes for the patient that is the right thing. But through sophisticated communication, it's possible to explore what is important to the patient, and advanced care planning for them could encompass all of these things. So food, drink, ventilation and resuscitation, spiritual and religious beliefs, who will care for them, and their preferred place of care and death. And it's important to say that they're two separate things. Often people want to be cared for at home, but they don't want to die at home. So those two need to be separated. So as a clinician, you might be wanting to achieve all of these, but you might not. Food and drink is often a very pertinent part of advanced care planning for patients with neurological disease, including motor neuron disease, because often they lose the ability to swallow and therefore sustain life with food and hydration. And this can happen quite early in the disease process. So whilst they're otherwise quite well and clearly not in the dying phase of their disease, and our ideal is to address that quite near to diagnosis before they lose the ability to eat and drink and make decisions about what they would and wouldn't want. So, for example, would they want any form of artificial feeding? And for most of these patients to be at home, it would need to be a PEG tube. And ideally, we like to insert these proactively whilst the patient is well, rather than waiting until they're unwell, because often that means that they've lost weight and their weight is too low for them to have a PEG feed. They're at risk of refeeding syndrome, and often their breathing may be affected also, and they can't lie flat for the procedure. So we often suggest to these patients that they have the PEG inserted whilst they're well and they're still eating and drinking. Some do decide to proceed, and some decide to wait, and some decide to never have it. The important thing that they know is that they can change their minds at any point. Ventilation and resuscitation is always extremely emotive and misunderstood, because ventilation and resuscitation is a medical intervention, which means that it's a medical decision as to whether it's appropriate for that patient. And it's still misunderstood even in the clinical setting amongst clinicians, that they feel that they believe that they have to give the patient the choice, and it's not patient choice. As I've said, it's a medical decision, but what we must do morally and ethically is explain to these patients why we've decided that it would not be appropriate to ventilate and resuscitate them. Sorry, resuscitate and ventilate, because it would be that way around. So for resuscitation, we're normally talking about it not being appropriate as the patient approaches their end of their life, and there's nothing reversible that we can do to improve how they are. So we believe as professionals that they are in the last days of their life, and that we should allow a natural death, and that we know that to resuscitate or attempt resuscitation is highly unlikely to be successful. And if it were successful, they would be even more unwell than they were prior to the resuscitation. And the likelihood of them dying in the ensuing days after that resuscitation is further increased. And also it's an undignified, invasive procedure. It's about 25% of resuscitation attempts in the acute settings, in the hospital setting, are successful, and of those 25%, about 15% survive to discharge. So we're talking about very low success rate anyway. Unfortunately, we're not helped by the media, because the media portrays, for example, on Casualty, that if somebody has a cardiac arrest, they're resuscitated, they sit up and they go home, which is never the case. And then ensuring that the patient understands that by resuscitating, often they're not unable to maintain their cardiac and respiratory function, so they would need to be ventilated. And once you're ventilated at end-stage disease, the likelihood of weaning you off of ventilation is also very, very remote. These discussions, if they're not done in a sophisticated manner, can be more distressing for the patient than they need to be, and the patient can be left feeling that there's nothing more that can be done, when in fact that is the absolute ceiling of treatment. So there's so much more that we will still do. So we might still offer feeding, we might still offer intravenous antibiotics or hospital admission and other treatments, but we would not resuscitate. A lot of clinicians fear having these conversations because they're inexperienced, but we do provide specialist training, and we as a palliative care team are more than happy to support and help facilitate these discussions if that's helpful. We have, alongside this, for about the last 8 years in England, introduced what we call a TEP, which is a treatment escalation plan. And we now say within UCLH Trust, and certainly it is being spread nationally as well, that you can't have a do not resuscitate order without also having a treatment escalation plan. So this will clearly state that whilst you wouldn't resuscitate the patient, that you would still do the following, and that is very individual. So for one patient, they might say they wouldn't want non-invasive ventilation, but they would want intravenous antibiotics, and they will want to carry on their feeding. So it's very individual, dependent on the patient's needs. And that therefore also doesn't take away all of their hope that we're still going to be alongside them and supporting them and maintaining their quality of life and treating their symptoms. Spiritual and religious beliefs are often neglected by us as clinicians and forgotten, but they are so very important. And unfortunately, spiritual and religious as two words are often put alongside each other, but they can be very, very different things to different people. And people who feel that they are spiritual might say that they're not religious at all. I think it's more a sense of self. And then other people have very deep-rooted religious beliefs that they find hugely comforting to them. And some people lose their faith because of the diagnosis. And it's important that we ensure that any extra support with that is offered, and they still have access to whatever ways they practice their faith, that they're still able to access those. So for example, if they're at home, would their religious leader visit them at home? And in hospital, making sure that we make the chaplaincy aware that they're in hospital and come and visit them as a form of support. The provision of personal care is always really difficult because some people, their loved ones, their next of kins, their friends, whoever's important in their lives, often want to do that, but the patient doesn't want them to because they feel a burden and they feel that they should go into a home. So it's exploring that with them together, as in the same room or separately, whatever feels right for them, as to what support they can have to enable that caring role to carry on, because often it can be for many months, if not years. And obviously that in itself brings carer fatigue, and it can bring resentment. And it's exploring what we need to do to support that to continue happening, or help the carer have the courage to say they can't do it anymore and bring in a care package into the home or think about a nursing home. And that's especially pertinent with people who are older, so people who are more elderly, who don't have the same level of function. And preferred place of care and death. As I said, a lot of people want to be at home, but they don't want to die at home. And it's important, again, that we as clinicians explore that, because it's quite hard to know at which point you decide to go to an alternative care setting for the end of your life. And it may be that things progress so quickly that we may not achieve moving them. But also people change their minds and feel that they are safe at home. Or the loved one may say, I cannot bear them to die in this house. I cannot live in it afterwards with that memory. So we often facilitate conversations between the patient and the carer as to what is the best thing for both of them, because we do have to take into consideration the person left behind and their grieving and bereavement process. And not everybody wants to die at home. Some people want to die in hospital because they feel safe there. Some are happy to go into nursing homes, and some would like to be in a hospice. I always stress with patients that we would aim to achieve a hospice bed, but they're not always available. So what is advanced care planning? So it comes under many different headings. So we have advanced statements or advanced wishes, which is non-legal document, but where we'd encourage people to, at the very least, have discussions with the people that are important to them in their lives, whether that's husbands, wives, children, friends, sisters, brothers, about what's important to them, so that the people around them have a sense of what it is they would and wouldn't want, which when and if that patient loses capacity and they can't speak for themselves, the family draw a lot of comfort from knowing they're doing what that person wanted, rather than guessing what they would have wanted, because those discussions haven't happened. And this can help both the patient and the people around them come to terms with what is happening within their family unit. Advanced decision to refuse treatment is a legally binding document and will be upheld in a court of law, and that needs to be legally signed and witnessed. But it also has to be very specific. So you can't just put, if I get a chest infection, I want antibiotics. It needs to state, for example, if I had a chest infection which was felt to be reversible, I would want to have oral antibiotics at home but not be admitted to hospital. Or I would want to be admitted to hospital and have intravenous antibiotics, but I wouldn't want non-invasive ventilation. Or I would want admission, I would want intravenous antibiotics, I would want non-invasive ventilation. You can't dictate to the medics what they do, but you can dictate what you do not want. In a court of law, a doctor could say, I knew that if I gave this person intravenous antibiotics, it was going to cause harm, so I made the decision not to. But it have to be very good rationale as to why those treatments weren't done. And they could say, I do not want to be resuscitated. I do not want to be artificially fed. I am aware that that would reduce my life expectancy. And this advanced decision to refuse treatment will only be used if the patient loses capacity to say what they want. or if they're not able to express it. But hopefully, if they're not able to speak verbally, we will have put things in place to enable them to communicate in different ways. And it's our responsibility as professionals to ensure that we explore all of the things available to enable that person to communicate. And it might just be thumbs up, thumbs down, as long as that's consistent. And we've recently had a patient like that, or blinking once for no and twice for yes. So it's our responsibility to explore those things. But if the patient loses capacity, then we would refer to advanced decision to refuse treatment. And lastly, planning for what death might look like, which we've slightly touched on. And as I've said, I've only met in 20 years of palliative care 2 people who are afraid of being dead. Everybody else that I've looked after have been afraid of dying and said they're not afraid of death. It's the dying process. And how will that be? How will you know if I'm distressed if I can't tell you? How will you know if I'm in pain if I can't tell you? I don't want certain people to visit me. I would like music playing in the room. I'd like my cat to be there. You know, things that are very, very personal, very individual to us, and that often we don't think of. We push it to one side, but it does help comfort the patient to know that we've thought about those things and held that in our minds, and it helps the loved ones to know that they're doing what they wanted, and it helps their grieving process as well. So often people are agitated and distressed towards the end of life because they haven't felt that they've put their affairs in order, and affairs in order means so many different things to different people. And sometimes it can be that they've lived with their loved one for 20 years, but they never got married, and they know that that can cause financial difficulties for their partner after they've died. So we have facilitated many last minute weddings, which have been beautiful and obviously incredibly emotional, but it is possible for that to happen literally in the last days of life. If it's not addressed, you know, if it is a last minute wish, it can be done. For want of a better term, deathbed wills, which I always find hugely distressing. But sometimes if we are involved and receive a referral for a patient at the very last minute, that's one of the things that always occurs to me, and I will always ask, are your affairs in order? And sometimes people haven't got a will, and then it can cause quite a lot of anxiety because they think it's too late. But again, that's something that we can get done very, very quickly. I've used solicitors locally in central London who I've rung them and they've come the same day, and sometimes waived the fee, or we've accessed charitable funds to enable that to happen. And that can give the patient a really some peace of mind and some comfort, knowing that something that they've just put off, they've done, and it leaves things in a more orderly fashion for those left behind. Things that often get forgotten, and we've helped to, not personally, but access hacking of accounts because people don't write down their passwords. I don't, and my husband hasn't got a clue what mine are. And it occurs to me quite often, and I still don't do anything about it. Passwords to accounts, which makes it really difficult. We had a gentleman recently who had just finished writing a book, and his wife needed to contact everybody that had been involved with the writing of this book. But he had a pin on his phone and she didn't know what it was. But anyway, we got there in the end. But it's just those little things that we just don't think about. Messages for people they love. So we often get a referral from colleagues saying, oh, can you come and do a memory box for this person? Can you come and help them do it? And whilst the concept is really rather lovely, the reality of a patient doing a memory box is very burdensome and hugely emotional and quite distressing. And they've obviously read about it, and you go and talk to them and they've read about it, or somebody's mentioned it, and then they feel this huge responsibility to do it, and then we just break it down into something smaller. So for example, just writing a letter to maybe their wife, their husband, their children, just a letter to leave behind, or a recording of their voice, rather than a memory box. The only time I've ever achieved that really is when I was caring for a lady who didn't have MND, and looked after her over several months, and she was very driven to do it, but it caused a lot of distress and took a lot of time and effort for her to do it, but we did achieve it. But more realistic is a letter or a voice recording or a gift, and that's often as much as they can achieve. And then obviously it's important for the patient, but also for the carers, to know that we're not going to suddenly disappear when they've died, that we will still be there as a form of support, and we do follow-up bereavement calls, and then we will signpost, because we're not qualified counsellors. Although we have counselling skills, we are not counsellors, we're not psychologists, and then we signpost and liaise with the GP to ensure ongoing support. And we do send a card, a sympathy card, with some contacts for them as well, but they will have our contact details. And sometimes people might ring us back once or twice, but we usually do 1 or 2 phone calls and then signpost on, depending what it is they need or what we feel they need. But most importantly, highlighting what we feel is a normal bereavement process or a complicated grieving process where they're not functioning as we would expect them to. But giving them permission to feel all of those emotions that we talked about earlier when a patient is diagnosed, the anger, the fear, the anxiety, the denial, all of those things which are healthy and normal. And that also helps us to have a little bit of closure as professionals, selfishly as well. So thank you for listening. I hope that's been helpful. I'm sure it's raised lots of questions for you all, and I'll make sure that my contact details, as well as all the contact details for further information, are available to you should you want to contact for further information, because that was a very whistle-stop tour of end-of-life care and planning ahead. Thank you.